and no ongoing treatment of malignancy. And as such, these patients should not be treated. I will talk a little bit about this group later on. So how are we doing with these quality of care indicators? Are we adhering to them? We have a lot of data to show that is not true. Suboptimal physician adherence to quality indicators has been shown in the UK General Practice Research Database. Allopurinol use, in which allopurinol use had practice deviation between 25 to up to 57% in dosing in renal impairment, in decreasing dose in concomitant uses azathioprine or 6-mercaptopurine, and in its use in asymptomatic hyperuricemia. Several studies show similar poor adherence in dosing of allopurinol with creatinine which is higher than 2 or higher, on allopurinol uric acid level not being checked at 6 months, and if a patient is on daily colchicine with some renal insufficiency, CBC and CPK not being checked at 6 months. And several studies have shown non-compliance between 22% to about 69%. Same thing has been repeated in several other studies. Continuous allopurinol use was shown in as less as 46%. Colchicine prophylaxis only given in 10%. And achieving a uric acid target level of less than 6 only in 20%. Dosages adjusted for renal insufficiency still showed better up to 69 to 77%. So how about patient compliance? We have a discontinuation rate of up to 90%. And non-adherence with urate lowering therapies among gout patients is exceedingly common. About 56% are non-adherent over the first year of therapy. What is this possible reason for frequent allopurinol discontinuation? Possibly inadequate patient knowledge of disease and the drugs, and physician knowledge, and perhaps a combination of both. What can we do? We have to start with educating ourselves. And of course, secondly, patient education, which will lead to a better and cost-effective management. How are we going to, and this is in part, the recommendations were generated with this background, and ULAR came up with several recommendations, stressing patient education and lifestyle changes. It is important to address comorbidities like hypertension, hyperglycemia, hyperlipidemia, obesity, and smoking. We know that hyperuricemia and gout can be part of the metabolic syndrome. Patients with gout seem to have a higher incidence of hypertension, etc. All of this listed here. There has not been a causal relationship established so far. However, this thing needs to be kept in mind, that when we treat one, the other hopefully is going to go down as well. Weight loss, if obese, reduce alcohol consumption, and low animal purine diet. Diet is, lots has been said about what to eat and what not to eat for gout patients. Please keep in mind that dietary restriction will only contribute to about 20% of control of gout. The rest has to be done with other things, be it lifestyle and obviously the drugs that you use. It's been seen that purine-rich red meat and fish correlated with high risk, but since fish is associated with cardiovascular benefits, therefore probably oily fish can be taken, or you can substitute that with your EPA acids, the free fatty acid supplements. There has been no association with total protein or purine-rich vegetables, which means please let them have their eggs and their vegetables. Low-fat dairy products may be protective. They seem to have a uricose-uric effect, as does vitamin C. Soft drinks, particularly sweetened with fructose, as they are in the USA. I don't know whether they are sweetened with what, but sweet drinks anyway, particularly if the sugar used is fructose. Coffee consumption may actually decrease